Well, we're going to start off by an introduction by Dr. Rodriguez, and she's going to give an overview of what Trinity does in the mental health department. And also, Helen, I got a couple of questions that maybe you can help me on after, and then Dan Keenan will make a few comments too, but you're on.
All right, thank you for having me. I am the Regional Director of Behavioral Health for Trinity Health of New England, and I have been the lead for behavioral health for Mercy Medical Center since 2020. In Mercy Medical Center, we do not have what is known as inpatient units for psychiatric care. So we do a lot of what we call care in place. So we manage our patients' psychiatric and addiction needs in the bedside while they're admitted for other medical conditions, or we manage them in the emergency department as they come over seeking services for behavioral health or other co-occurring disorders. So that being said, we have a team composed by licensed independent social workers, psychiatric nurse practitioners, psychiatrists, and addiction medicine experts. We also include in our team a recovery coach, and we have what we know as a community health worker, which is a very special role that I will spend some time talking to you about. So how it works is that people can come in. We touch people in two ways. The first way is that people come through the emergency department and they're coming with a chief complaint of behavioral health condition. They might have an unstable pre-existing condition. We see a lot of people with mood disorders, bipolar, depression, suicidality, schizophrenia. Sometimes they walk in on their own seeking voluntary services, or sometimes we are part of what the first responders use to stabilize community crises. So we have EMS and police officers sometimes bringing patients to us, or the both of them together rather. When patients come to the emergency department, we have a dedicated area for behavioral health. That area is locked. It's separated from the general population, and it provides a different set of safety features in everything we have there. Our doorknobs, our showers, our toilets. Everything that is in there is designed to reduce risk for suicide while patients are under our care. While patients are there, we evaluate them not only psychiatrically, but medically. So they get a medical assessment. That's the first thing we do. We make sure that there's not something medical happening with them. We do labs. If they come with injuries, some of our patients come after a fight or after a fall or after an accident, and we make sure that that's taken care of. And with that information, we evaluate the mental health condition of that person. And that mental health evaluation is conducted by a social worker, a behavioral health specialist. And in combination of what we see from the medical assessment and the psychiatric or the behavioral assessment, we make a recommendation. We say we recommend this patient going into an inpatient facility for further acute psychiatry treatment, or we recommend services in the community. In Mercy Medical Center, I think what makes us different and what we are so proud of is that we collaborate, and every patient gets case management, right? So not only, okay, you don't need to go to the hospital, so then go to the community and figure it out or follow up with the community behavioral health center. We do care coordination for them. So we often make sure that crisis has the BHN crisis for this area follows up with the patient within 24 hours. We make sure that if that patient or that person has a medical condition or a mental health condition and they have a provider already established, that they go and follow up with them. We talk to them and let them know that they were in the emergency department. Some patients lose their medication. Some patients that we serve are experiencing housing insecurity.
That's
Yes, Naina.
Bhutan.
No, that's the
Bhutan is okay.
Okay. So some patients are experiencing housing insecurity. So it's often that our patients lose medications or the medications that they need that brought them to the emergency department. So we do a lot of bridge medication fill-ups. So we make sure that they just need 10 days to get through their next appointment. We make sure they have those medications. So we evaluate what is really the condition and why these patients deteriorate to come to us. We are trying to work off people's strengths, and sometimes people don't want to go to the hospital, and they, with a good plan, they really can stay in the community. So we work off of that. We also engage a lot the families and the collaterals. We work with a lot of people of color and people from the Hispanic community, people that live with adults that live with their grandparents, with their parents that come to us. So we need to make sure that the housing situation that they're returning is secure, and that those folks that are receiving our patients back feel safe and feel like they have the resources available to take care of them.
So you do these evaluations as the people come in, and then you can decide when they come in, if it's safe enough for them to go back in their homes, or they may have to stay.
Correct. And if they're safe enough to go home, what do they need to really be safe? Because the concept of safety is really different for different people. Depending on resources, depending on condition, depending on history. That's what we evaluate. We not only evaluate the symptom, we evaluate how the patients have responded before to treatment, what treatment has worked, what resources have been helpful. And with that, we use that to basically, it's almost like a work of art, right? Like you orchestrate a treatment plan that fits for that person. So it becomes very individualized. One of the most important things that I have to say for us as being a small community hospital, we depend on our community stakeholders and other providers of care to really support the work that we do. So we spend, from the leadership aspect of things, we spend significant amount of time collaborating with programs. Like we have a recovery coach in RDD. That recovery coach is subcontracted by Gandara. We have a harm reduction kit that I brought for you if you wanted to take a look at. That those are provided by Tapestry. Tapestry comes to our nurse orientation and they talk about wound cleaning for people with substance use disorders. They talk about harm reduction and anti-stigma education. So we do a lot of community engagement. We also have something very special in our emergency department and around our teams, that is our community health worker. So Trinity Health of New England invests in community health and well-being as part of our Together. What is the initiative?
Together here?
No, the initiative for the
Transforming Communities.
Transforming Communities Initiative. So Transforming Communities Initiatives have created this role of the community health worker, and every single patient we see has an assessment of social influencers of health. So we evaluate their status of housing, food access, education, finances, and with that assessment, we make referrals, and many times our community health worker receives a referral and can work on those aspects of care after the patient discharge our care. That is very important because what we see in our communities of Springfield, it's patients that have complex social situations that they don't only need a pill or a safe place to be, they also need access to food, they need access to education, they need a plan in how to improve her overall well-being. So that is an approach that has shown some success for us. There's a lot of barriers to it, like it's a complex thing to pull, but I think that we're making strides towards the right direction. And that's our ED. That's one thing we do. The other big piece that Mercy does is our addiction consult service that currently is funded by the Department of Public Health, Bureau of Substance Use and Addiction Services. They fund us in a yearly basis.
Is that a grant?
That is a grant. That is a grant. And we are currently have received probably like close to 1 point.
The initial grant was 1.17 million. It's up to $6 million, with some potential opportunity to help support services.
So with that money, we're able to fund the staff. So one of the issues that we have as a hospital, and this is true for all hospitals, is that added services that are given to the bedside that we bill as professional services, we only get paid back like a portion of our bill. I'm gonna give you an example. If we bill for a doctor to see a patient for opioid use disorder at $300 consult, we're probably receiving anywhere from $80 to $120 back. The doctor's salary doesn't work like that, right? Like benefits don't work like that. We do often have that against us. So these funding from both cities and from the state really help us continuate and figure out sustainability as we go without having our services suffer, which is huge. Mercy has had a very long-standing commitment to people who use substances since the sisters were running Mercy, right? It has been a big deal for us. We are committed to take care of the most vulnerable, and these are most vulnerable people because our patients who have substance use disorders experience cardiac concerns, infections that require long-term antibiotic stabilization, many times require surgery and recovery. Many of them deteriorate to the point that they need care and places to live that need nursing assistance. So taking care of the addiction portion is part of the healthcare that they deserve.
Counselor, could I just make one
Yeah.
point regarding that grant that Mercy received?
This was a $6 million
Yeah,
grant?
up to $6 million, but that grant was really with the support of our legislative delegation who has championed these issues on behalf of the community and the Department of Public Health. They recognized the work that Mercy was already doing. This addiction consult service was in place before the grant opportunity was there, and they looked at that service that was being provided and said it needs to be supported and attempted to replicate that in other locations. So they created a grant program around the addiction consult service that Mercy was already providing. So it really was a recognition of the great work that Dr. Rodriguez is leading.
Fantastic.
Yeah.
I just have a question. What's your biggest challenge in recruiting and retaining mental health professionals? Is that a problem? I know that Helen always talks. Helen, can you hear me?
Yes.
Hey, you're on mute.
I can.
Yeah, because you always mention how it's very difficult for you to find nurses. And I'm sure that that's a problem with any part of the profession, that it's hard to keep and retain professionals when you hire them. They'll go somewhere else. The retention's got to be a little bit of a problem. How do you handle that? And I want to acknowledge Zaida Govan, City Councilor in Springfield.
Good afternoon. Good afternoon, Dr. Rodriguez.
Good afternoon. See you.
And this is right in your profession.
Yes.
It is. I just got done seeing a client, so I wasn't planning on coming to this meeting, but I'm glad I'm here to see at least Dr. Rodriguez and the commissioner. It's always good to see you both.
Fantastic. Yeah, so we're talking about the retention of the professionals that they have at the hospital.
Yeah, that is a hard thing to do.
So that's a two-folded question for us because behavioral health in Mercy, it's its own separate niche. And the people that report to me that are behavioral health experts, we actually have no vacancies in our team. And we've had the same team since 2023. So, and we've had some people leave in other apps that impact our team in other areas. But for us, how we manage retention is we find opportunities for everybody to work on something that really makes them passionate. Healthcare is about money, but it's also about calling and belonging and feeling a purpose. And we noticed that a lot during COVID and how people were like, I thought I wanted to be a nurse, but I really don't want to do this. This is really hard. So it is a hard job. And we have created internship programs. We have one of our supervisors has a very successful internship program. She came up with the idea and we say, go ahead. this is the pathway, you do it, you own it. And she's done an amazing work creating a pathway for students from Westfield State University, Springfield College, both from undergrad and bachelor's degree to come through our social work internship and train. And that has fulfilled her cup. That she's done a lot of work with that. She's received recognitions and that has worked really well. We have our providers that they come up and say, we should do better our evaluations for capacity. And I say, let's do it. What do you need? So I see myself as a leader, as a facilitator of bridging those opportunities for my team. And they feel pretty content because they feel like they're not only a job description, they're a person that as they see needs there can tap into that. And that happens in the context of having also my leadership and people that I report to giving me the empowerment and the freedom to do things and trust in me. So I think that a lot of trust needs to be built between employers, employees in healthcare. Creating opportunities for professional development is really important. And obviously money is important as well. We need to look about compensation and about safety. We take safety really, really, really serious. We have workplace violence committees that we participate. We look at how we're triaging our patients, how our patients are searched. And we look at it consistently from a multidisciplinary lens. So we are always communicating to our staff, this is, we care about you and we care about your safety and employers are there for our colleagues and our colleagues then are there for our patients. And they take care of our patients, we take care of them. So it has to show that kind of like chain of care to create an ecosystem that really thrives. But we do have issues with nurses and doctors leaving. I think also our doctors are pretty stable. Have been there. We have doctors that have been at Mercy for 20 something years. So it's a lot of a culture thing too.
I mean, one of the things I noticed when I looked over the statistics that I shared with Helen Calton, Commissioner Calton last year, was the overwhelming use of the emergency rooms. And one of the things that really struck me was the number of people coming in with alcohol abuse, hundreds. And is that like alcohol poisoning? Because we lose people to that too. People overdose on alcohol.
Can I just say that is a great point. Mercy Medical Center actually completed a 2-year performance improvement plan project for the state of Massachusetts and Mass Health, where we increase our screening and assessment of women of color coming with substance use disorders, with alcohol use disorder, because alcohol is one of the main reasons of admissions to med-surg. Complicated detoxes are a high percentage of how people end up in the ICU. And you're right, we don't talk about it. I think that we don't talk enough about it. So we engage in this process of educating our nurses on why we need to be non-stigmatized when we ask screening questions. So we have these screening questions and they're all the same for everybody. But the body language that you use, how you ask them, how comfortable the person feels. And for women specifically, when having their kids taken away is on the line, they will lie about these things. And sadly, they will shy away from help that could be very convenient in a timely manner to save their lives. So we actually saw an improvement in most of our screening, and we still see a gap on women of color, Hispanic and Black women, from reporting to accepting treatment. So we still have some work to do in that population. They are coming forth and they're saying that, they're being truthful with their alcohol use disorder, but not necessarily feeling comfortable enough to engage in treatment. So I think that the community of health workers, we all need to continue to take accountability on that and figure out ways that we can engage those communities better.
I want to acknowledge City Council President Tracy Whitfield. Thank you so much, Tracy, for attending this meeting.
You're welcome.
And would you like
Hi,
to
everyone.
Hi, Tracy. How are you? Would you like to say a few words?
No, but thank you for joining us and having the meeting. I'm just here to listen and learn. So I appreciate the work that you all are doing.
Thank you, Tracy. My other question
Mr.
was,
Chair, I'm sorry.
Yeah.
to interrupt. What was this meeting for?
On mental health, behavioral health, and with the hospital, with Trinity Hospital.
I see. Okay, I wasn't sure. And, so I guess a question I think I have for Dr. Rodriguez, and I'm not sure if who else is there. You want to badge this one? No. Um, with I think there's a merger happening. Am I right about that?
I was gonna bring that up. Go ahead.
Yeah. So for the merger, how is that going to affect, the services for everyone?
So Counselor, the merger with Bay State Health, so that it's actually an acquisition of Mercy by Bay State Health is what's called a member substitution, which means that Bay State will move into the corporate role as the sponsor owner of Mercy Medical Center, and which means all services that are currently in place will continue in place. That's the way it is structured, and from everything that is needed in this community, I think that is what will happen.
Okay, yeah, that's good to know. And because I know that Mercy Trinity Health actually does provide a lot of great mental health services. I've had the experience to, refer people over the years. And I'm really glad that those services will continue. Thank you, Mr. Chair.
Yep. But
The alcohol use disorder is a big deal. I think that there is, our communities have experienced a reduce in alcohol use. I think that the alcohol sales are down. So I think that there's a lot at the end of prevention that it's going on. Generations are using less of it, but it's always a concern in the end of the hospital because when people come to us with alcohol use disorder, they're pretty severe. And they require medical interventions that are pretty high level. And we're there. So right now with the closure of the community detox of Carlson and BHN, we know and we're expecting that some of those folks that usually went for alcohol detox do that to that level of care, that we will take care of them in the emergency department. We have been working with phenobarbital protocols where we load patients based on their weight with phenobarbital. This medication helps patients not go into delirium or complications from alcohol withdrawal. It happens in the emergency department. You can load somebody with a dose and within a day or less, they can transfer to community support programs such as CSS. So we are hoping that these things that we've been working through the Addiction Concert Service, because they're best practice medicine, can help bridge the communities to all the changes that are happening because they're already in place at Mercy.
Last night during our meeting, Zaida and Tracy, we were talking to the commissioner about homelessness and the big problem it is in the city of Springfield. And my question is, how do we reach out? Because the homeless people have big problems too. They have they have drug addiction, and on top of being homeless. So how do we reach out to those people? And then when you do reach out to them, how do you find them somewhere to live?
So that is a systemic question. So I don't think that one piece of the puzzle can solve that. I can say that best outcomes are seen in communities that put housing first, that believe in providing people places to live regardless of conditions of mental health, substance use. And the philosophy behind it is that giving somebody the basic needs of food and housing will help them stabilize the other things, not the other way around. There are programs that require for people to graduate certain steps or to finish certain levels of treatment to get housing. So I think that if we had more of the housing first phenomena, I know that there are also the Department of Public Health and Mass Health invest in residential programs. So we can help stabilize substance use disorders and occupational concerns while people are recovering slowly. So then we can build up to the point that they're stable enough so they can handle, the independence that is needed to keep a house. But it's not an easy task. I think there's not a one size fits all. I have stories of patients that have done amazing in a shelter and have graduated into a house. But there's people that really struggle being on a shelter where they see other people use, and they do need to be in a sober community. So I do think that we need to think in a multifactorial and opportunity community to solve that problem.
Do the shelters actually refer people to you?
Yes, but usually, so remember, we're an emergency department, we're a hospital. So when people come to us, they're fuming fire. They're not coming in because they think that they're gonna get into a crisis 2 days ago. They're coming in because somebody caught the crisis happening. So one thing that Massachusetts has done since 2022 with the Chapter 177 Act, where they have created a lot of funding going into community-based programs, right? We have the CBAC and all of these programs that are like easy access in the community so people can go there before they need to come to the hospital. So I think that when they come to us, they refer them to us. By the time that they come to us, they probably need to go to psychiatry. So they're not coming into a place that we're just patching them up and sending them back to the shelter. Many times they need to go to a higher level of care.
Yeah, and if I may, Mr. Chair, and I'm sorry, Commissioner, go ahead.
No, you go ahead. I can wait. I just want to respond to the healthcare homelessness situation.
You might say what I'm gonna say, so go ahead, Commissioner.
Well, no, I was just going to just remind us that the city of Springfield does have the Health Services for the Homeless Health Center. That is, we have a $1 million contract with Mercy Medical Center. There is a psychiatric nurse who is a part of that care team. And so I just wanted, to your point, Councilor Santinello, I just wanted to bring up the fact that there is within our system the ability to care for unhoused individuals in healthcare. I would also say that care coordination, case management, and outreach really is the core of the opioid work that we're doing through Tapestry, Gandara, and New North Citizens Council. I'm sorry. I just wanted to center us in the fact that the city does continue to try to support unhoused individuals, and we do have clinical services that we are providing. When I speak about the healthcare workforce shortage, I certainly am talking about nursing services. We're still looking for a physician, actually for our Health Services for the Homeless program. We just hired a full-time dentist for our oral health program. I said all that to say that there are a lot of moving pieces that really go to the heart of caring for the unhoused people with mental health challenges as well as addiction. And you can't separate those things. Substance use disorders and mental health live in the same place. And so when we compartmentalize them, we do a disservice to those individuals who are struggling with substance use disorder. I apologize, Councilor Govan, please.
No, thank you so much, because that's actually I was going to bring up the healthcare for the homeless piece of it, right? And like Dr. Rodriguez said, when you're treating someone with mental health issues, substance use issues, and homelessness, we need to have coordination, collaboration, which is exactly what I think the city and Commissioner, you're doing with Mercy Hospital, with Gandara, with Tapestry. That collaboration, I think the one piece that we're missing here in our city is the housing piece, right?
Yeah.
There was this about a three-legged stool when we're treating people with, mental health issues, substance use issues, and housing is just one piece of it. And what Dr. Rodriguez is doing at her agency is a piece of it with the care management, recovery coaching, and the coordination there, as well as what Commissioner Carlton Harris is doing at healthcare for the homeless. The housing piece is very important because that gives people stabilization. Like, Dr. Rodriguez said, if you go back to the shelter and everybody around you is using and you just got out of detox, it's going to be hard to stay clean if you're homeless. You know what I mean? It's not impossible and it can be done, but it's a bigger challenge that way. So that one piece that's missing for everybody, I don't think it's just unique to Springfield. The entire country struggles with this. Housing for people who are homeless, who are trying to get stabilized with their recovery, mental health recovery, substance use recovery, or whatever it is that they're trying to do. So I think last night Tina presented a grant that she has that helps with this. But we need a lot more of that. Thank you, Mr. Chair.
Thank you, Counselor. What do you see as the biggest challenges moving forward in your department?
I think that we continue to be challenged by sustainability of our services, of billing for the right services. We find these services that we know work, for example, the community health worker embedded in the hospital, addressing social influencers of health before you leave, telling you where to find food, how you can find housing, bridging programs where we are letting, folks that are going to nursing homes go into a hotel for a couple of days so they can transfer there safely and following up with them. How we find a way to monetize, just not to make money, but just so we can continue to pay for these services. Because I think that it's continued to be a challenge. Like we have these amazing programs. They're funded by the state. They're funded by the federal government, by the cities. But it's not sustainable forever. So we do our task often while we are running these programs, and when we see what works, to really have an stoic view of what is necessary, what is not, what is good to have, what is must have, and make those evaluations and have those determinations before our programs end, so we can make our ways into sustainability. And I think that's something that Mercy has done really well. We know what's nice to have. I know I can beef up my programs in different ways, and it will be cool to have this and that, but I know what is a must have. So if tomorrow I need to decide on what stays and what goes, I know exactly what that is for my program. And I think that that's a challenge that often in community mental health work and community substance use work, administrators and leaders, we are often tasked to think about what if this funding is not there, and think creatively. And that's when the power of collaboration really comes in, because I don't need to do it all. I don't need to do it perfect. I just need to know who does it and have a good relationship with them. We made a very conscious decision years ago that we were not going to hire our own recovery coaches, that was not our neck of the woods. We were a hospital. We were continue to do what hospitals do, but Gandara did it really well. So we contracted with Gandara. We give a piece of the pie to Gandara. They give us the recovery coach. They give us the bilingual piece, the cultural piece that we need for the north end of Springfield, and we keep things current. So it's having that mentality of collaboration, and continuing those relationships, which, to be honest, on itself is a full-time job, because we need to make sure that contracts are in place, that MOUs are up to date, that we are being conscious of any payment increase that happened to that staff that is reflected in our line items. So there's some sustainability of those contracts as well.
Do you write your own grants? I mean, do you write the grants, or do you have some grant writer?
We do it as a team. So for example, these grants that we have right now, I wrote with our medical director in our community and health and well-being. We wrote it, she perfected it, she put it in like grants language, and that's how we move along. I think that we also ask for help within other resources that we have. And Trinity has been also gracious to have some consultants. Sometimes when we're going for big grants, they come and they help us with the grants. But sometimes I am the one who finds out on a meeting that there's money, and we go back and we say we need to apply, and we figure it out. And I think that we've been successful that way.
The $6 million grant that you have, is that state money?
State money. Department of
State
Public
and
Health.
federal.
Yeah,
Yeah,
right.
we don't put the.
There is a little federal in
Yep.
there?
Yes, yeah.
Do you see that continuing, or do you see the Trump administration possibly cutting you?
So I don't think personally, we've addressed this with visas and TPH. They are not concerned about that. Because a lot of this comes from opioid settlement money that is at the federal level, and also from other funding that is allocated for this particular concern. So we don't see it like that. What we are going to see in our funding is a slow decrease as we work in our sustainability. So the Department of Public Health is saying, we're gonna give you this support, we're gonna give you this money so you can continue to run your programs. But what I'm expecting of you is for you to work hard on sustainability, for you to figure out how to build, for you to figure out how to work on your contracts and get the money you need to go back. And they're providing the technical support for that. So that's part of the services that we receive. We have technical support through them, and we're working in our billing and infrastructure so we can become sustainable.
I just want to say that Commissioner Carlton, nobody's better at finding money than Commissioner Carlton. She every time I'm at the council, we're always approving a grant, which is a good thing. Helen, do you want to wrap up and ask or finalize your thoughts?
No, I want to thank Dr. Rodriguez certainly for the work that she's done. Your impact is really very well known, and your community, the way in which you embrace community is very, very important. And of course, Dan, whom I've known for many years, thank you for your support over the years as well. I think if I could say anything, it's about care coordination and silos. And so one of the entities that we fund, it's about care coordination. We have so many agencies and organizations doing amazing work, such as Trinity. However, the communication is lacking in terms of knowledge around what we all do, how we can seamlessly refer individuals. I think we're all doing a great job, but hopefully through some of the work that we're doing together, we start to sort of break down those barriers around working together, because there are barriers around working together, because at the end of the day, this is really about residents, for me, of the city of Springfield, that I really know what the data looks like and how challenging it is as far as substance use disorder, mental health, behavioral health. We have a psychiatric nurse that we've hired through Mercy Medical Center who sits in our health center, and we get an opportunity to really be immersed in some of what is going on or what she's finding. So again, let me just stop there and say thank you for being here. Thank you for the information. Look forward to continuing the partnership that we have with Mercy Medical Center. And Dan, good to see you. Thank you.
Thank you so much, Commissioner Carlton. Zaida, would you like to say some final words?
Oh, no, just thank you for having this meeting. It was really nice to see Dr. Rodriguez. I haven't seen her in a while. We're always running and doing things, but I think this issue of mental health and substance use is something that we're going to be dealing for a long time. We've been dealing with it for a very long time, as Commissioner knows. Back in the 90s, when we were up in Mason Square passing a basket around trying to figure out how we were going to get rides to people, to get to detox. I'm hoping that the new program with the outpatient detox is going to work well. I've got some a little anxiety around that because, as you know, Dr. Rodriguez, you said, alcohol is one of the most dangerous drugs to detox from. You could really, die from it if you're detoxing, without medication. So I'm hoping that, that will work out. I'm glad that they're having listening sessions around it. BHN is. So I'm excited about what the future looks like. And I'm excited that Commissioner Carlton Harris talked about collaboration, because that's my favorite thing to do, is to collaborate. Thank you both. Thank you all. Thank you, Mr. Chair.
Thank you so much. And I just want to reiterate what I said earlier, that when I was looking over the numbers last year, I could not believe the number of people at both hospitals with alcohol emergencies. And some of them don't make it, they die. And we're losing them. And that was higher than any other category of drugs, was alcohol abuse. So I'm glad we're working on that, but like you said, Councilor Gabon, there's so much more we have to do.
Absolutely, always.
Well, thank you so much, everyone. And I plan on in the next couple of months taking a tour of both Bay State Medical and Trinity on their facilities. And as a committee or other councils, I'd like to see if they'd like to come along for that tour. Thank you.
Yeah.
Thank you. Thank you.
Thank you. Bye, everyone.